thank Dr. Saad and the whole team of the Mega Online Association for their continuous effort. I'd like to thank Dr. Abduraouf and all my colleagues for inviting me for this very nice event and evening. And I want to present our young generation who are, we are very proud of them. And one of them is Dr. Mohamed Yaseen, a lecturer of anesthesia, surgical ICU and pain management at Cairo University. This topic will be pre-operative sepsis management in pediatric anesthesia.
Thank you, Doctor. Thank you, Dr. Azza. Okay. First of all, I want to thank Dr. Saad Mahdi for his great efforts, and much thanks to our professors for allowing me to share in this scientific day. My topic today will be pediatric sepsis from PICU to OR. I'm Dr. Mohamed Yaseen, lecturer of anesthesia, surgical intensive care, and pain management, Cairo University, Diplomate of European Society of Anesthesia and Intensive Care, and Fellow of the College of Anaesthesiologists in Ireland. The objectives of my lecture will be definitions, recognition of sepsis in pediatrics, management guidelines, fluid-resistant shock, catecholamine-resistant shock, and the considerations for anesthetist. Since 1992, there were a lot of consensuses concerned about sepsis and septic shock. However, two of which were concerned about pediatrics. Society of Critical Care Medicine and European Society of Intensive Care Medicine established the Surviving Sepsis campaign in a trial to improve definition, recognition, and management of sepsis and septic shock. And definition of sepsis and septic shock in pediatrics more or less follow the definition of that in adults. And as we know, the definition of sepsis is a dysregulated immune response against infection, and septic shock is considered to be a subtype of sepsis associated with cardiovascular dysfunction. Regarding the diagnosis of sepsis and septic shock in pediatrics, actually it is defined in the context of systemic inflammatory response syndrome criteria in presence of infection. The criteria of systemic inflammatory response are core temperature more than 38.5 or less than 36 Celsius degrees, tachycardia or bradycardia, tachypnea, leukocytosis or leukopenia. 2 out of 4 criteria are required in addition to infection for diagnosis of sepsis. But what's different in pediatrics is that abnormal temperature or abnormal leukocytes should be one of these 2 criteria. The 2005 consensus, which was the last concerned about pediatric sepsis and septic shock, defined cardiovascular dysfunction as despite giving isotonic fluid bolus of more than or equal 40 milliliters per kilogram over 1 hour, there are hypotension, a requirement for vasoactive agents, or 2 of the following criteria, like unexplained metabolic acidosis, base deficit more than 5 milliequivalents per liter, elevated lactate level double the normal range, oliguria less than 0.5 milliliters per kilogram per hour, prolonged capillary fill time more than 5 seconds, and core temperature, core to peripheral temperature gap more than 3 Celsius degree. It's worth mentioning that hypotension is one of the late signs in pediatric population, which indicates a very late disease. So it's very important to know these criteria that may indicate that the patient is hypoperfused, however, he has a normal vital parameters. As a pediatric population has a large reserve, so it's very late to present with hypotension. So let's go through this case scenario of a 2-year-old boy presented to the emergency and accident department with abdominal distension, occasional vomiting, and red currant jelly-like infrequent stool. he was diagnosed by the surgical team to have a complicated intussusception. Intussusception is one of the most common causes of intestinal obstruction in pediatrics, and it commonly occurs after a severe gastroenteritis. The vital signs of this boy were heart rate was 155 beats per minute, mean arterial pressure 45 millimeters mercury, respiratory rate is 40 breaths per minute, temperature 39 Celsius degree. He has altered mental status, capillary fill time more than 3 seconds, and urine output 0.3 milliliter per kilogram per hour. So how to recognize if this patient is in sepsis or not? Apparently he has a cause, he has an underlying cause of a complicated intussusception, but we want to know if the patient has sepsis or septic shock. If there is suspicion of infection, I will ask myself if the patient is hypotensive or not. And this will be in the context of the normal vital data according to the age group of this patient. And as we said, this patient is a 2-year-old boy, and the heart rate was 155, mean arterial pressure was 45, and respiratory rate was 40. So according to this table, the patient has abnormal vital signs regarding the heart rate, mean arterial pressure, and ventilatory frequency. So I will identify this patient as unstable, so we should start resuscitation. But if not, if the patient does not have these signs, so I will search for, and as I said before, hypotension or instability is a late sign in pediatric population, so I have to search for the worrisome features, more than 2 features or 1 feature with comorbid condition like immunocompromisation, post-operative less than 3 months. This can guide the management after that. These features are core temperature less than 36 or more than 38.5 Celsius degrees, altered mental status, altered the peripheral perfusion like flash capillary refill less than 1 second, as we will say in the next slide, which is called the warm shock, or prolonged capillary fill more than 3 seconds, which is called the cold shock. Inappropriate tachycardia. So 2 of these features or 1 feature with comorbid condition is a strong clinical suspicion. So if this is the case, we will start the resuscitation. If the patient does not have any of these worrisome features, so we will deliver the routine care. So apparently our decision will be to start resuscitation. And as we know, the difference between life and death, it is a matter of time. And it's very important to know that time is a very important factor in the management and resuscitation of sepsis and septic shock. One of the protocols for management or resuscitation of pediatric sepsis and septic shock was designed by the American College of Critical Care Medicine, which is the first hour bundle. We will start to manage the patient according as it is an emergency. So we will start as ABC approach. So first we will start with high flow oxygen. The patient apparently may need further, after that may need respiratory support, but we can buy some time to start with high flow oxygen, and then we will place monitors. Don't waste time placing invasive monitors at this point, but focus on starting the resuscitation as we will mention. So we will apply the non-invasive monitors like pulse oximetry, ECG, non-invasive blood pressure, core temperature, ventilatory frequency, and urine output. You have to examine the patient frequently, like the monitor every 5 minutes. Regarding the airway patency, the respiratory function, especially if the patient has a pulmonary cause of sepsis or like pneumonia, the pulse and the capillary refill, cardiac gallop and hepatomegaly, which can indicate congestive cardiac failure, glaucoma score, and peripheral skin temperature. It's very important to reassess the patient every 5 minutes because this population and this disease is hyperdynamic, so you have to monitor every 5 minutes. Within 5 minutes, you have to secure an 2 IV access or intraosseous access if there is difficulty in insertion of intravenous access, and you can use the intraosseous route for anything that you can use the intravenous route. After insertion of the intraosseous line, it's very important to withdraw the sepsis panel, especially the blood culture, because the next step will be to deliver the antibiotic. So it's very important to withdraw the blood culture before antibiotic therapy, but not to delay antibiotic therapy. If there is any difficulty in insertion of the intravenous line, and it apparently will take some time to insert, it's very important to deliver the antibiotic through the intramuscular route. So after insertion of the intravenous line and withdrawal of the sepsis panel like CBC with differential, blood culture, blood gas and lactate, blood glucose level and electrolytes, metabolic and DIC screen and cross-matching, we will start fluid resuscitation in the form of boluses of isotonic solution like Ringer's lactate. We can give boluses of 20 ml per kilograms, and it's expected to give up to 40 to 60 ml per kilogram in the first hour. As I said, it's very important to deliver the antibiotic very early in the management, optimally after withdrawal of the blood culture. The antibiotic therapy, as you know, it depends upon the situation, the site of infection. But one of the regimen recommended by the American College of Critical Care Medicine is to give ceftriaxone, vancomycin, or metronidazole if there is a suspicion of anaerobic organism like an intra-abdominal source of infection. If the patient is not responding well to fluid therapy and within 15 minutes, you have to think about the vasoactive agents. To decide which vasoactive agent you will give to the patient, you have to differentiate between the two different types of shocks in pediatric population, which is the cold shock and warm shock. The cold shock is characterized by that the patient has vasoconstriction, so he has cool extremities, prolonged capillary fill, narrow pulse pressure, and this is apparently due to low cardiac output and high systemic vascular resistance. So my aim here is to increase the cardiac output by giving adrenaline, milrinone, or we can add noradrenaline if there is no sufficient response to adrenaline. Regarding the warm shock, this patient had warm extremities due to apparent vasodilatation. So he has warm extremities, he has flash capillary fill less than 1 second, wide pulse pressure, low diastolic pressure. All these parameters indicate vasodilatation, low systemic vascular resistance, and high cardiac output. So my choice will be a vasoconstrictor like noradrenaline or vasopressin. If the patient is not responding well to catecholamines, so I have to search for the underlying cause. In our case, for example, the patient has a complicated intussusception, so my plan will be to optimize the patient for surgical intervention. But you have to rule out other causes like pneumothorax, tamponade, increase in intra-abdominal pressure. Regarding steroid therapy, you know that steroids are one of the medications that can be given in sepsis and septic shock in adults, but this issue is debatable in pediatric population. The recommendations of the American College of Critical Care Medicine is to deliver steroids based on laboratory results or laboratory evidence of adrenocortical insufficiency, or if the patient has a history of steroid intake recently. We will search for thyroid dysfunction, and if there is, we will replace the thyroid hormones. And if all of these measures failed, we can consider extracorporeal support like ECMO. As you see here, we inserted peripheral lines like the intravenous or intraosseous routes. You can give the intravenous fluids, antibiotics. You can give the vasopressor either through the intraosseous route until you stabilize the patient. You can reassess the patient for adequacy of the airway and the breathing and the circulation. And you can, at this point, after stabilization, you can initiate the respiratory support if in need. You can insert the invasive line if in need. You can insert a central line if the patient is on vasopressors or inotropes. So if we come back to our case, we faced this patient in the intensive care, and we defined him as unstable, and we resuscitated him adequately. So the surgical team is willing to explore the patient to get rid of the source of infection. So I will ask myself, am I ready for anesthetizing this patient? It's very important to check the endpoints of resuscitation. Like to the capillary fill time to be less than 2 seconds, to have warm extremities, normal blood pressure for age, normal pulse, normal mental status, urine output more than 1 milliliter per kilogram per hour, normal glucose level, especially in the young infants who are at risk of hypoglycemia due to the lack of glycogen stores, and normal ionized calcium. So before starting to anesthetize this patient, we have to ensure that this patient is stable. So when this patient is introduced to the OR, I have to, as I said, to ensure the stability of the patient before induction of anesthesia, I will apply the full monitors that he was on in the intensive care. I will pre-oxygenate this patient, and I will induce him by rapid sequence induction. This patient has some sort of abdominal or intestinal obstruction, so he is at risk of aspiration. So I have to induce the anesthesia through rapid sequence induction. But it's very important to know that sepsis and septic shock make a major pharmacokinetic and pharmacodynamic changes. This is related to the underlying physiological abnormality, the vasodilatation, hypotension, the decrease in the circulating volume, decrease in the albumin or the plasma proteins that may affect the protein binding of the drugs, hypoperfusion of the kidney and liver that may affect the metabolism of anesthetic medications. So you have to reduce the dose of anesthetics, and you have to titrate these medications to response. The intraoperative management, you have to titrate the anesthetics targeting the hemodynamic and perfusion parameters. Hemodynamic parameters like the blood pressure and heart rate, and the perfusion parameters like the capillary fill time, the lactate level, and urine output. It's very important to optimize these parameters intraoperatively by maintaining the fluid management and vasopressor and inotropic support. You have to check blood glucose level, especially in young infants, as I said, to optimize the acid base and electrolytes. It's very important if it is a lengthy procedure to redose the antibiotics every 4 hours, and maybe earlier if there is large volume fluid resuscitation that might dilute the antibiotic to a subtherapeutic range, or if I gave the patient back the RBCs, for example, I have to redose the antibiotic intraoperatively to ensure that it is within the therapeutic range. Regarding the ventilation, we know that sepsis and septic shock are major causes of acute respiratory distress syndrome. Besides one of the very important risk factors, which is the large volume fluid resuscitation, which put this patient at risk of fluid overload and hypoxemia. So not to do more harm, we have to apply the lung protective strategy. Regarding the post-operative management, we have to continue the ventilation in the post-operative period with the protective lung strategy to transfer the patient to the PICU to complete the management there, while monitoring all the parameters during transfer, and pay attention as well to pain control, either by regional blocks. So for example, if this patient is doing an exploration, we can do rectus chest block or bilateral tap block, or even caudal anesthesia, which could be a concern, sepsis in the epidural caudal anesthesia in this patient, and we can use other oral medications for pain control. So to conclude, sepsis and septic shock are major causes of morbidity and mortality in infants. In South Africa, for example, 40% of admissions to the PICU are due to sepsis and septic shock, and mortality can be over 10%, and it will be different between low and high income countries. So it can be over 10%, can reach 17%, like for example in South Africa. Clear understanding of pathogenesis of sepsis and septic shock in the context of pediatric physiological changes is crucial. Timely and organized recognition and management is a hinge point in survival. Every 1 hour delay in management can worsen the outcome and worsen the morbidity and the mortality of these patients. Antibiotics and source control are the weapons against infection. So from the start of management, I have to pay attention to the antibiotic therapy and to optimize the patient for a pathway to control the source of infection. Lastly, be dynamic in a hyperdynamic situation. It is very common that these patients change the shock phenotype from cold to warm shock. Maybe during resuscitation the patient develops fluid overload, so you have to monitor the child frequently. You have to monitor resuscitation, and you have to monitor your management further. Thank you.
Thank you so much, Dr. Mohamed.
Thank you, Dr. Yassin.
Very illustrative, and you were very dynamic as well, and you covered all the aspects. We interacted all the measures, including the pain control. Thank you so much.
Thank you, Dr. Yassin.
Dr. Mohamed, can I ask a question, please? What about coagulopathy, management of coagulopathy in such cases?
Actually, coagulopathy is one of the abnormalities that may happen during sepsis and septic shock as a part of the multi-organ dysfunction in this situation, unless the patient has an indication for correction of coagulopathy, like bleeding, or he's going for surgery. So we will not interfere with coagulopathy. We will manage sepsis and septic shock. But if he is going for surgery, we have to correct to minimize the risk of bleeding in the intraoperative period.
In your experience, what about low platelet count if there is no active bleeding?
Thrombocytopenia is very common in pediatrics during the sepsis and septic shock phase. But we have, if there is no active bleeding, we can wait for this unless it's critically low, like below 50,000.
So with me, I always I don't recommend giving it unless there is an active bleeding.
Yes, yes.
Thank you very much.
I agree with you. Thank you, Dr. Amal.
Dr. Mohamed, في سؤال, is there a role for albumin use?
Sorry, doctor?
Is there a role for albumin use in such
Yes. Yes, the American College of Critical Care Medicine actually studied the best IV fluid for resuscitation of pediatric population, and there was an options like normal saline, lactated ringer, or albumin. We know that normal saline, we have a large debate around normal saline, but till now there is no strong evidence against its use in pediatrics. So we can use isotonic fluids, or we can use albumin in certain situations, like if the patient has a pulmonary cause of sepsis, or he has hypoxemia, for example. So my fluid resuscitation might worsen the hypoxemia more and more. So using albumin 5% might decrease the volume that I can use, and might decrease the extravasation of fluids in the lung. So it might be helpful in management of septic patients who have hypoxemia or a pulmonary cause of sepsis. So it can be used, and it is described.
It can be used in certain situations.
Yes.
But you prefer the use of the crystalloids.
Yes.
Thank you.
Thank you, Dr.
Any questions?